Hello friends, I'm Dr. Rejo. I'm presenting a paper on decoding the interstitium from reticulations to radiomics HRCT as a game changer. Presenting author being myself, Dr. Rejo, and co-author being Dr. Jyoti Tapadi, HOD, Radiology Department, institution is Ashwini Rural Medical College, Kumbhari. Introduction. The interstitial lung diseases encompasses a wide spectrum of conditions, including the idiopathic pulmonary fibrosis, UIP pattern, the NSIP pattern, hypersensitivity pneumonitis, sarcoidosis, connective tissue associated ILDs. HRCT provides a non-invasive alternative offering high sensitivity in detecting the parenchymal changes such as ground glass opacities, reticular changes, honeycombing, traction bronchiectasis. Conventional chest radiography is limited in sensitivity and specificity for ILD diseases. HRCT has revolutionized the evolution of ILDs, allowing detailed characterization. The AATS and ERS emphasize HRCT as a critical tool in the diagnostic algorithm. The study aims to evaluate the diagnostic performance and clinical utility of HRCT in ILDs and its future course and radiomics. So aims and objectives of this study is study the spectrum of HRCT findings to evaluate the diagnostic accuracy of HRCT, to correlate the HRCT findings with clinical lab and histopath data, to assess the role of radiomics in evaluation of HRCT. Materials and methods, study design with prospective observational study. Study population with patient clinically suspected to have ILD referred for HRCT chest. Study design was carried out at tertiary care center over 12 months. Inclusion criteria being adults greater than 18 years with clinical suspicion of ILD. Clinical suspicion of ILD includes symptoms presenting like dyspnea, dry cough, crackers, abnormal chest radiograph. Exclusion criteria being patients with acute infections, known lung malignancies, and contradictions for CT scan. Sample size being 120 patients over the year period of 1 year, that is 1st August 2024 to 30th July 2025. Ethical considerations were taken after IEC approval. Informed consent from the participants were taken. HRCT protocol scanner was multi-detector CT 32 slice Siemens somatoscope scan at our center. Patient position being supine, breath hold, full inspiration. Expiratory scans were taken to evaluate air traffic in patients suspected to have HSP or bronchiolitis. Scan range from lung epizas to costophrenic angles. Acquisition was helical. Slice thickness being 1 to 1.5 mm thin slices. For reconstruction, no contrast was needed, and lung window with level approximately 1500 HU and window level being 600 HU. Data analysis, HRCT findings were categorized into patterns, the UIP pattern, the probable UIP pattern, indeterminate UIP pattern inconsistent with UIP or alternate diagnosis, correlation with clinical history was done, gender, age, drug history, exposure like occupational exposure with EFTs, with serology, and whenever available, histopath considerations. Two thoracic radiologists independently reported and assessed the HRCT using the standard guidelines. Patterns were UIP, probable UIP, indeterminate UIP, NSIP, other occupational pneumoconiosis or HP, sarcoidosis, extent scoring per lobe 0 to 100% with fibrosis score depends upon reticulations, traction bronchitis, honeycomb and gel. Radiomics was also evaluated by quantitative imaging analysis with in-house software by taking the pictures of intensity, texture, pattern, the heterogeneity to quantify the image. Clinical data was taken for symptom consideration. How long were the symptoms? They are like lack of dyspnea, gender, male, female, who were more affected, history of smoking, occupational exposure, pulmonary function test, whether it was showing restrictive pattern, obstructive pattern, or mixed pattern, outcome, the treatment decision, the exacerbation, 12-month survival. Then for radiomics, the lung intelligence healthcare kit trial version was applied to this affected segment of the lung tissue of HRCT for all patients. The lung lobe segmentation algorithm, the LK software used this particular VNet algorithm. Artificial intelligence healthcare kit was used to extract the features from the segmented lungs. The radiomic features captured various texture, shape, intensity variation that may not be appearing in the standard imaging evaluation. Results of the population of 120 patients, the mean age was more than 50, approximately 56 plus 12 years. The patterns most common was the UIP pattern, which accounted 55%, then the NSIP pattern, then the hypersensitivity pneumonitis, then the other or occupational pneumoconiosis, like cold workers and silicosis, then sarcoidosis. Diagnostic accuracy was for HRCT was for UIP was almost 90%, which is very good. Sensitivity was 80%. Correlation was also good with FVC, obstructive pattern, and DLCO. Prognosis: patients with fibrosis greater than 20% on HRCT had significantly higher mortality. This was a graphical real representation of the data we accumulated. So most common is UIP, then followed by NSIP, then hypersensitivity pneumonitis, then connectivity disorders, the pneumoconiosis and sarcoidosis, most common affected by the men with age more than 50 years and smokers. Discussion: HRCT provides an essential diagnostic clue in the evaluation of ILDs. Our findings confirm that HRCT pattern recognition, particularly for UIP, has very high diagnostic specificity, consistent with the prior reports and studies like Ragu et al. In 2017 and Lynch. HRCT extends scoring correlated strongly with the pulmonary functions. Inter-observation agreement was also substantial, and the prognostic utility was also evident. So we see along the actual images of the patients we had. This is the UIP pattern. There is peripheral, basal predominant reticulations with honeycombing seen in this patient. As we see here, is the basal predominance and the predominant reticulations with honeycombing features. Then in the NSIP, we see ground glass opacities with fine reticulations, as you can see, and subpleural flaring is less. The characteristics of NSIP. Then in hypersensitivity pneumonitis, there were centrilobular nodules with mosaic attenuation and air trapping, which can be better evaluated in expiratory film, as we said earlier. Then sarcoidosis, basically perilymphatic nodules with upper lobe predominance and architectural distortion is seen here. The perilymphatic nodules. Connective tissue disorders. This may have a UIP pattern or NSIP pattern as seen in the figure 1 and figure 3 respectively. There can be also common signs like four border sign and straight border sign, as you can see here. Straight border sign. Differentials on HRCT. Ground glass opacity can be seen in pneumocystis pneumonia, DIP. Nodular pattern can be seen in hematogenous METS and biliary infection. Cystic pattern can be seen in LAM and LC histiocytosis. Mosaic pattern can be seen in obliterative bronchiolitis. Septal thickening can be seen in pulmonary edema. Limitations of the study: because it's a single center study, it limits the general usability. Referral bias to a tertiary center is there. Semi-automated software has its own dependence on the algorithm, and short-term follow-up for a long-term outcome has its limitations. Conclusion: HRCT is an essential non-invasive tool now considered as a gold standard in ILD evaluation. It was high diagnostic accuracy. It's reproducible, quantifiable, and prognostic insights are there. Radiomics is an emerging pathway, as we see. It gives a quantitative assessment of the different qualitative aspects of the HRCT and reduces the inter-observer variability.